Greetings, Chasing COVID Cohort Study participants. I'm Dennis Nash, a professor of epidemiology at the City University of New York Graduate School of Public Health, and I'm also the principal investigator of the Chasing COVID Cohort Study. In March of 2020, our team of scientists and public health professionals at the CUNY Institute for Implementation Science and Population Health launched the Chasing COVID Cohort Study. The study ran throughout the course of the COVID-19 emergency, and it represents one of the most comprehensive community-based studies of a pandemic. In this video, our team is going to present some highlights from this project, which could not have happened without the engagement and commitment of you, our study participants. At the end, we'll also share some information about our next big project, which will involve a cutting-edge study of at-home rapid tests for multiple respiratory pathogens, including flu, RSV, and COVID. I'm going to turn it over briefly to Will, who many of you have gotten to know over the last several years, for a formal thank you on behalf of all of us.
Hi, everyone. This is Will. I was the study manager for the Chasing COVID Cohort Study and has been your point of contact for the past 4 years. For those of you who have wondered who Will from C3 was at the end of every email and text communications, this is me, and I'm not a robot, in case anybody's wondering. It is an honor to be here today, and I would like to first and foremost thank you for your dedication to this endeavor, for it is truly commendable. So during the course of the study, our team gained invaluable insights into the dynamics of this pandemic, and that is all thanks to your unwavering engagement and participation. So today, as we gather to discuss our findings and the future of the cohorts, we want to first extend our heartfelt gratitude to each one of you for your resilience, your commitment, and your contribution to the pursuit of knowledge in the face of adversity. It has been a tremendous honor for myself and the rest of the team to share this journey with you. So just thank you so much.
Thanks, Will. What motivated our team to design and launch this study? Well, first, we experienced a workplace outbreak of COVID-19 early on in March 2020. While we were recovering or at home in quarantine, our team became very concerned that what was unfolding in New York City could become much more widespread with potentially profound impacts on public health. All of us wanted to find a way to leverage our experience to learn from what was an unprecedented situation in the hopes of informing the COVID-19 response going forward, as well as the response to future pandemics and public health emergencies. We knew that whatever kind of research study we might launch, given that a pandemic and lockdowns were underway, it could not be an easy time for people to engage in research. And any study that we launched, it would have to allow for participation from home. So the CUNY Institute for Implementation Science's mission is to conduct research with potential to improve population health outcomes. So clearly, COVID was aligned here. And luckily, though, that experience included extensive work conducting online cohort studies with at-home specimen collection. And so that greatly helped us move in the direction we needed to for this particular situation. Moreover, community-based prospective studies were exactly, in our view, what was needed early on in the pandemic, because the routine surveillance that was happening and the cross-sectional seroprevalence studies at one point in time were limited in many ways and didn't provide a true picture of what was unfolding. For example, the risk factors that were identified in these studies were not really well characterized. And no studies, to our knowledge, were able to characterize the true reach of the public health interventions that were being deployed, especially among people who became infected. And because it's hard to assess these things. So all of these things really motivated us to rapidly and design and launch the national cohort study that we did at a time of such great uncertainty and worry. So initially, our study objectives were to estimate the incidence and drivers of SARS-CoV-2 infection, as well as severe disease and death. And we also wanted to assess the pandemic's impact on psychosocial and economic outcomes, We wanted to assess the uptake of pandemic mitigation strategies such as masking and testing when that became available, contact tracing, isolation and quarantine, and vaccines when they became available. So from the outset, you can see here that while the study was very much focused on COVID-related outcomes, it was not only about COVID, but also other dimensions and outcomes that would be impacted by the pandemic and its response. And this, in our view, is a unique feature of our cohort study. As the pandemic evolved over time, it became clear that we needed to continue following the cohort for more than a year, and also that we need to add some new study objectives. So we added objectives that were aimed at assessing the incidence and risk factors for long COVID, and we also wanted to assess the impacts of newly available vaccines and eventually oral antivirals. To achieve all of these objectives, as you know, we deployed questionnaires at regular intervals and mailed specimen collection kits to you so that you could then self-collect and return dried blood spot specimens, which were used for serologic testing for COVID-19 antibodies. So this initial study launch in March of 2020 was supported by funding from the CUNY ISPH, as well as the CUNY School of Public Health Dean's COVID grant program, which was put in place rapidly. And in order to achieve our objectives, we needed and applied for a large year-long emergency grant from NIH. The initial funding that was internal just was not enough. So we needed NIH funding. And luckily, in June of 2020, that proposal was funded and allowed us to provide things like participant incentives and to proceed with testing, both things necessary for the success of this project. In the beginning of the study, none of us, including the NIH, expected that the COVID-19 pandemic would go on as long as it did. So that meant to go further with our objectives, we needed to continuously write new research grant proposals in pursuit of funding to support all aspects of the study. So things like the participant incentives, the specimen shipping, the laboratory testing, and the staffing. And that also necessitated us applying to other institutes of NIH, such as the National Institute for Mental Health, and who provided some COVID funding for our work, and also to Pfizer. So during March to July of 2020, 6,740 participants enrolled in our study. And while participants in our study are not necessarily a representative sample of the US adult population, our cohort participants are geographically and socioeconomically diverse. For example, with 15% being age 60 and above, 19% are Hispanic, 13% Black, and 7% Asian. 13% were unemployed at the time of enrollment. 40% had incomes, household incomes less than 50,000, and 57% were at increased risk for a severe COVID-19 outcome by virtue of their age or an underlying health condition or daily smoking. And of those who were younger participants, the 18 to 49-year-olds, 48% of those participants also had an underlying condition or were smokers. And importantly, for early phases of the pandemic, 19% of our cohort were essential workers, with 12% of them being healthcare workers, and about half of those healthcare workers reported that they were providing direct patient care for people with COVID-19. And as you all know, we sent you specimen collection kits in the mail and asked you to collect and return dried blood spot cards to us. These specimens underwent serologic testing for SARS-CoV-2 antibodies, which tells us about past infection by the virus. And it allowed us to figure out, importantly, who had already been infected at the time of their initial specimen collection, as well as who had not. And with repeat serologic testing over time, we could identify the timing of the initial, the rough timing of the initial infections, for example, by noting where someone had a negative test for serology followed by a positive one. And going forward, we could also look at the persistence of SARS-CoV-2 antibodies over time in those that had repeat serologic tests. So this slide shows participant engagement in the cohort over time. Starting at the far left with the dark blue bar, of the initial 6,740 people who enrolled in the study. The light blue bars show the number of people that completed each of the questionnaires that we sent out, and the orange bars show the number of people who provided a dried blood spot specimen at each of the 4 time points for serologic testing. And while we lost participation from about 1,500 individuals early on in the study, the engagement of those of you who stayed with us throughout the entire arc of the pandemic has been extremely impressive and consistent. For example, in 2023, about 5,000 of you, or about 75% of the initial cohort, were still with us and had participated in at least one study activity during that year. On average, despite everything going on since March of 2020, CHASING COVID cohort participants have completed 20 of the 22 questionnaires that we sent out, and on average submitted 2 dried blood spot specimens, with 25% of the cohort participants submitting all 4 specimens. This slide gives a snapshot of COVID infection history as well as vaccination in the cohort as of the end of 2023. By that time, since the start of the pandemic, 60% of you had at least one COVID infection based on the information and specimens that you provided. And of those with a prior infection, 43% had evidence of multiple COVID infections, and 18% reported experiencing long COVID symptoms at some point during follow-up. Many of those with a history of long COVID were still experiencing symptoms as of our most recent questionnaire in late 2023. On the right of the slide, you can see the distribution of vaccine doses that people in the cohort had received as of the end of 2023. And of the 4,657 respondents in this questionnaire, 34% had received the most recent COVID-19 vaccine formulation as of having received the dose since mid-September of 2023. The CHASING COVID Cohort Study findings have received quite a bit of attention in the news and other media outlets, which enhances the impact and reach of our work. And this slide features just a handful of examples of news items that spanned local, national, and international media outlets. Next, I want to turn it over to several members of the study team who will share some highlights and some of what we've learned from the CHASING COVID Cohort Study.
Hi, CHASING COVID participants. I'm McKaylee Robertson, a co-investigator with the cohort and epidemiologist at ISPH. Early in the pandemic, the Centers for Disease Control and Prevention was reporting that Black and Hispanic persons were more likely to be hospitalized because of COVID-19 than are proportionally represented in the United States. In this study, which was published in Emerging Infectious Diseases, we tried to understand some reasons why that might be happening. And we examined 3 aspects that might increase the risk of COVID-19 infection or illness. First was the potential exposure to the SARS-CoV-2 virus. This got at aspects related to someone's ability to social distance, for instance, whether they could work from home. Next, we examined difficulty accessing healthcare, for example, whether someone has health insurance or a primary care provider. We also examined risk or susceptibility to severe COVID-19 disease, such as whether someone has an underlying chronic condition which would increase the chance of becoming very sick if you were infected with the SARS-CoV-2 virus. Now, the figure is showing you all these different measures by race and ethnic group. Blue is the Hispanic group, orange is Black non-Hispanic group, and gray is the white non-Hispanic group. And what we found is that Hispanic and Black participants had more potential exposure to the virus, more barriers to healthcare, more infections, and more hospitalization when compared to white participants in the cohort. And in turn, participants who have more exposure to the virus, again, this is the inability to social distance, then have a greater odds of infection or hospitalization, and participants with more barriers to accessing healthcare have a greater odds of hospitalization. Taken all together, these findings help to explain the disproportionate burden of infections and COVID-19 complications among Hispanic and Black persons. In this study, which was published in Public Health Reports, we looked at food insecurity in the cohort. which is limited or uncertain access to adequate food due to money or other resources. The figure on the left is showing you food insecurity over approximately the first year of the pandemic. And we observed that 40% of the cohort were food insecure, and Hispanic and Black participants and participants with children were more likely to report food insecurity. And over time, around 15% of the cohort were persistently food insecure. This meant that they repeatedly reported limited or uncertain access to adequate food. And during the pandemic, public health measures that were enacted to prevent the spread of the virus negatively impacted businesses and employment, resulting in job losses and decreased income. So also as part of this study, we looked at food insecurity by industry and income loss. That's the figure on the right. And we found that people employed in construction, leisure and hospitality, and trade and transportation and utilities industries had the highest prevalence of both food insecurity and income loss. The key takeaway in this study is that the pandemic resulted in widespread food insecurity in our cohort, much of which was persistent. And future policies should focus on the needs of those working in industries vulnerable to economic disruption and ensure those experiencing food insecurity can access food support programs.
Hi, my name's Avantika Srivastav, and I'm a research scientist at ISPH. A major part of the CHASING COVID cohort has been the serology testing we've done using dried blood spot samples. In this study, which was published this year in Scientific Reports, we used data from those samples and compared infection rates in the cohort over time, looking at seroincidence before vaccines were available and comparing it to the vaccine era based on serology information we collected from March through June of 2022. The first time period had an almost completely unvaccinated cohort, while by the end of that second time period, about 90% of our participants had been vaccinated. About half of the people in this group in this time period had been boosted once, and a quarter had been boosted at least twice. And based on these findings, or based on these two groups and time periods, we had a number of key takeaways. The first was that infection rates were much higher overall in the vaccine era compared to earlier on in the pandemic, before vaccines were available. They were nearly 3 times higher in the second era, but significantly lower among participants who engaged in various protective behaviors. And these infection rates are what you're seeing on the graph to the right. And you see the first bar is infection in the pre-vaccine era, and the next 6 bars are infections in the vaccine era compared across different levels of vaccination. So that second bar, which is the tallest, is completely unvaccinated participants. And these participants they had more than 5 times the risk of infection compared to people in the pre-vaccine era. And you see similar rates among people who were partially vaccinated or had only completed a primary series. However, this decreased significantly with more boosters, which you see in the last 3 bars on that graph, where people who had at least 1 booster or 2 or more had the lowest rates of infection. Even accounting for things like age, and comorbidities, we found that increased infection risk persisted in the vaccine era compared to the pre-vaccine era. Apart from boosters, there were a number of protective behaviors that reduced infection risk over time in the pandemic. Some things were protective in both these 2 time periods, such as masking, social distancing. However, over time, new behaviors that were associated with increased infection risk emerged in the later time period, such as having children in the household and only sometimes social distancing with people you so even though there was an increased risk, or even though boosters and protective behaviors did not completely eliminate risk, they did significantly lower it.
Hi, my name is Rebecca Zimba, and I'm a research scientist at the Institute. I'm going to describe two studies focusing on understanding preferences for SARS-CoV-2 testing features, both published in the Journal of Medical Internet Research, Public Health and Surveillance in 2020 and 2021. In the summer of 2020, access to tests was still fairly limited, but we knew home tests were being developed and wanted to understand people's preferences for COVID testing and how additional testing modalities might impact overall testing uptake. After participants finished the second regular survey, open between July and September 2020, we invited them to complete a discrete choice experiment, which compared various hypothetical testing scenarios like the one shown at the right. From their responses, we could determine which factors, type of test, specimen type, venue, and turnaround time, participants valued the most. We found turnaround time to be the most influential factor, followed by test type, specimen type, and venue. Combining preferred features increased simulated uptake of testing from 78.4% with testing in a doctor's office using a nasopharyngeal swab to run a PCR test with results in greater than 5 days, to 97.7% with testing at a pharmacy using a saliva sample to run PCR and serology with same-day test results. We also wanted to explore whether there were groups of participants with different preferences and how different testing scenarios could increase testing uptake within each group. We found 5 groups of preferences that varied across the features of testing scenarios. Some participants valued less invasive testing, others valued having information about current and past infection, and some were unlikely to test at all unless it was at home. In this simulation, comparing multiple alternative testing scenarios, our baseline testing strategies included drive-through and walk-in community testing with nasopharyngeal swab and 48-hour turnaround time. Testing uptake increased from 82% with those baseline strategies to 98%, adding less invasive testing, PCR and serology testing, and at-home testing scenarios. The biggest increases were in the largest group, who preferred less invasive testing with PCR and serology results, and the smallest group, who preferred testing at home, if at all. In this latter group, testing uptake nearly doubled.
Hi, I'm Rachel Pilchlob, an affiliated investigator with ISPH. One thing that we chose to investigate were the perceptions of the COVID-19 vaccine among those who are under-vaccinated. We distinguished under-vaccinated as participants who had not reported completion of the primary vaccine series, meaning they had only had one vaccine rather than 2 doses, or who reported they had had no booster doses by fall 2022 when we conducted this investigation. The results of this investigation are published in the journal Vaccines in 2023. What we chose to do is ask participants about their perceptions of the COVID-19 vaccine and the COVID-19 vaccine booster. As you can see from the chart here, there are a variety of different specific items that we asked participants. We asked them if they agreed, disagreed, or didn't know about the statement. The majority of participants were able to recognize that the COVID-19 vaccine did not make you magnetic. As you can see, 76.6% of participants disagreed with that statement. In contrast, 38.8% of the participants who responded to these questions agreed with the statement the COVID-19 vaccine was developed too quickly. The range of statements that we asked participants are shown on this slide. When we looked across those types of statements, we were able to generalize the statements into 3 distinct categories: concerns or perceptions related to vaccines' safety, concerns or perceptions related to the vaccine's efficacy, and concerns and perceptions related to vaccine ill intent. Ill intent was the kind of category that we used to characterize statements like the COVID-19 vaccine can make you magnetic, or contains tracking devices, implants, or microchips. Some of those more extreme statements that seem to have been dispelled at this point related to kind of COVID-19 vaccine misinformation. We examined these categories in particular to think about how in the future different sorts of messaging interventions could be designed to address some of the ongoing concerns that participants had. And again, we specifically were looking at participants who had initially been willing to get a COVID-19 vaccine, but had stopped kind of continuing with their vaccination series, with the notion that these folks may be what we were calling a movable middle, may be willing to continue with vaccine uptake if we could address their underlying concerns. Now, in particular, among the 510 under-vaccinated participants, this group that we were just discussing on the last slide, the primary group of concerns that they had were related to vaccine efficacy. And you can see on this slide the statements that related to this efficacy category. Those statements were, I don't believe I need an additional booster dose. There is not enough evidence that the booster dose is effective. Concerns about long-term side effects of the vaccine, already having had COVID, planning to get a booster but not yet having had time, and concerns about short-term side effects. So these concerns all related to their rationale for not continuing to get vaccinated and not yet receiving the COVID-19 booster. So as we think about kind of the takeaway from these statements and from this efficacy-related concern, this is a critical area to focus public health and intervention messaging in the future.
Hi, everyone. My name is Madhura Rane, and I am a research scientist at the ISPH. In mid-2021, when COVID-19 vaccines were approved for children aged 12 and above, we asked parents of children aged 2 to 17 years about their intention to vaccinate their children against COVID-19. And these findings were published in JAMA Pediatrics. We found that 48% of 12 to 15-year-old children and 56% of 16 to 17-year-old children had received at least one dose of the vaccine by June 2021. Hesitancy to vaccinate children immediately is higher among parents of younger children, which is shown in the darkest gray bar in this bar plot. Overall, 26% of parents expressed hesitancy to immediately vaccinate their child. Vaccine hesitant and unvaccinated parents were less likely to immediately vaccinate their children. Even so, 10% of the parents who were themselves vaccinated still expressed vaccine hesitancy for their children. Black and Hispanic parents and parents with less than high school education were more likely to express hesitancy, while parents with previous COVID-19 experience, such as those who had a previous COVID-19 infection or knew someone who died of COVID, expressed higher willingness to vaccinate. The most common reason for hesitancy was concern about vaccine-related long-term adverse effects in children.
Hi, C3 cohort participant. My name is Jenny Shen. I'm a research scientist at CUNY ISPH. And this study was presented as an oral presentation at the 2023 Society for Epidemiology Research Conference. In this study, we aim to answer the questions: what is the risk of long COVID among adults who got COVID-19 for the first time as a breakthrough infection after receiving at least one dose of vaccine? Do breakthrough infections in vaccinated adults less likely to cause long COVID? This figure on the left is showing you how we specify the target trial protocol. By applying eligibility criteria, there were 4,503 unique eligible participants enter the first trial, and in total, we emulated over 27,000 person trials. Long COVID incidence among vaccinated and unvaccinated person trial was 6.6% and 14.7% respectively. As shown in the figure on the right, participants who completed at least one dose of primary vaccine before breakthrough infection had a lower risk of long COVID compared to those unvaccinated individuals. This study was published at Open Forum Infectious Disease. In this study, we aim to answer the research question: how is the uptake of Paxlovid and the Lagevrio among highly vaccinated adults who were infected with SARS-CoV-2 infection between December 2021 and October 2022? Who are more likely to receive Paxlovid among those who are at higher risk of severe COVID-19 outcomes and who are eligible to be treated? We find that at the height of the pandemic, just 2% of COVID-19 patients reported getting Lagavulin, and only 15% reporting getting Paxlovid among those considered to be eligible for the drugs. Paxlovid uptake increased over time, which was aligned with the national campaign Test to Treat, which is aimed to increase antiviral access. We found participants who were older than 65, had higher income, had type 2 diabetes, and with a history of long COVID, reported higher Paxlovid uptake compared to participants who were younger, had lower income, without type 2 diabetes, and those without a history of long COVID.
Thanks so much to the team for those brief presentations of some of our scientific publications, which again would not have been possible without the engagement and commitment of you, our study participants. I want to return to some other things that we've learned from you more recently, where we solicited some feedback about your experiences participating in the CHASING COVID Cohort Study. In late 2023, over 4,600 of you told us about some of the main things that motivated you to continue your participation in the study over the last 4 years. This information is useful to us, of course, because it can help us improve the experience of our research study participants going forward. And we also believe that this helps to increase your engagement, which in turn increases and helps us maintain good quality research output. Looking at the small graph on the left, your responses included about what motivated you to continue participation included that you thought it was an important study, you enjoyed being a part of it, the monetary incentives helped, and the fact that it was possible to learn things from participating, the trust in the research team, and also the access to serologic laboratory testing. And then looking to the larger graph on the right, when we asked you about specific aspects of study participation and how well they were received or not, you can see that most of you thought that things like how much time it took to complete questionnaires, or the clarity of the questionnaires, or the frequency of contact with the study team and other aspects were either just right or perfect in your view. A smaller percent of you felt neutral on some of these issues. But we can also see here that about 10% of you felt that the time to complete questionnaires and the clarity of the questions could be improved, and as could the clarity of instructions for specimen collection. All of this feedback has helped us and will help us going forward in the way that we conduct this kind of research. So thank you for sharing. One other part of this feedback, we asked some open-ended questions, which are the kind of questions where you don't have to choose from the response options that we've included, but you can put in information that anything you want to tell us. And we asked, as we near the end of the CHASING COVID Cohort Study, are there any comments you'd like to share about your experience with the COVID-19 pandemic or this study? And I'll read just a few of them here to give you a sense of what we heard. Thanks for the opportunity to join this program. We rode this roller coaster ride together and made it. Also, the gift cards I received helped me through this very difficult financial time. We also heard that I feel closing everything down was ineffective and set our children back. Trying to work a full-time job while my child completed virtual learning was very stressful. I feel the vaccines were pushed on everyone without proper testing. The government and media response has made the public not trust either. We also heard that the study was well run, well put together, and enjoyable to be a part of, except for the pricking part. And I greatly enjoyed being a part of the study and feeling like I'm making a difference. As someone with long COVID, I hope that you might be able to conduct more research on that. So many of us are affected by it, and it's scary, so limiting, and so little is known. Again, this kind of feedback really helps us and helps improve the way we do our future work. And speaking of our future work, we want to also tell you about a project that our team is going to be doing next. It's a 2-year study that builds directly on the CHASING COVID cohort, and it's called Project PROTECT, where PROTECT stands for Prospective Respiratory Outcomes from Tracking and Evaluating Community-Based Testing. the next phase. The objectives for this project are to investigate the incidence and symptom severity of COVID, flu, and respiratory syncytial virus, or RSV, using new multi-pathogen at-home rapid tests. There's a picture of the test we'll be using in the study on the right. It's very similar to the one, to the at-home rapid test many of you have used for COVID, but this single test includes lines that indicate whether you have RSV, COVID, influenza A, or influenza B. If you have none of these, only the control line will be present, and it means you're negative. If you have one of them, there'll be an indicator line in one of the 4 places on the test strip, indicating which virus is present. And if you have a co-infection or more than one of these infections happening at the same time, the test will show more than one indicator line, depending on which viruses are present. Our second objective here is to better understand the short and long-term effects of respiratory viruses on daily life in the context of existing vaccines and background immunity and treatments. As I mentioned, individuals enrolling in this study will participate with us for up to 2 years, but this study will be different in a few important ways from the Chasing COVID Cohort Study. The main difference is that we'll be more focused on collecting information during the acute phase of respiratory infection and testing. So when a study participant experiences symptoms of acute respiratory virus infection, we'll ask them to log those symptoms with us and to administer at least 2 of the multi-pathogen rapid tests. If any of those 2 tests are positive, 2 more tests will be administered on days 7 and 10 after symptom onset. We'll also ask participants to collect and mail us nasal swabs and saliva samples collected during this period, and these will be tested by PCR at our study laboratories. There will be no finger sticks or blood collection for those of you that didn't like that part of the Chasing COVID cohort. Participants who test positive on any of the rapid tests will also be asked to complete monthly questionnaires for about 6 months following their infection, so that we can assess the frequency and severity of post-acute symptoms such as long COVID. And we all remember the issue of asymptomatic infection. And so during surges in respiratory virus transmission over this 2-year study, we will select randomly several participants to do at-home testing. And these will be participants who don't have symptoms, and that will allow us to describe and assess the frequency of asymptomatic infection for all 4 of these respiratory viruses. So you may be wondering, how can I participate? Like the Chasing COVID Cohort Study, we're aiming to recruit around 6,000 adults from around the US into this study, beginning in late spring 2024. And in fact, as of today, our current launch date is projected to be mid-June. And the focus of this study is primarily on those people who are at higher risk for severe outcomes resulting from infection by one of these respiratory viruses. So those aged 50 and over, and those with an underlying health condition or comorbidity. We'll be reaching out to Chasing COVID cohort participants first to offer an opportunity to participate, and we'll encourage all people that we invite to invite others in your networks to learn more about the study and participate if they're interested. As with the Chasing COVID Cohort Study, all study activities can be conducted remotely and at home. And for more information about the study, we've provided a link here that you can follow, or you can use the QR code at the bottom right of the slide. That's all we have for you today. I would just like to say, on behalf of our team at the CUNY ISPH, I want to again extend our deep gratitude for your contributions to this work to date. And we hope that you'll consider sticking with us for this next phase of our research that builds directly on your earlier contributions. Thanks so much for listening.